So today we'll be discussing shielding in England and other things related to blood cancer patients and shielding. So I'm joined by my colleague Nick York, who's going to also be speaking as a patient speaker today. Thanks for joining us, Nick. And also joined by Renata, Amit and Adam, three haematologists from various locations across the UK. I'm sure they'll introduce themselves at some point, but thank you all for joining us as well. So I'm going to begin by just giving a brief overview of where we're at with shielding in England. I know it's becoming sort of increasingly confusing for patients to sort of work out whether different bits of advice apply to them. So I've tried to break it down into various stages, and hopefully this will make a lot more sense to you. So just to recap, who was supposed to shield back in March when we were all being asked to stay at home more often. So just to go over this again, leukemia, lymphoma and myeloma patients and other blood cancer patients were specifically mentioned in the list of people who were asked to shield because they were likely to be at extra high risk of severe COVID-19 if they were to catch it. And the aim with that was to take a cautious approach. There may or may not be people within blood cancers who are more at risk than others, but given this was a new virus, it was very difficult to tell at the time. The big question on everyone's lips, I think, is will this continue? Now, this is, we were expecting an announcement last week on this matter, and unfortunately that announcement has not yet come. So just to recap where we're at, the initial 12 weeks that was initially sort of put in place in the letters and things by the government did end on 30th of June. Some confusion was caused by patients not all receiving their letters at the same time. I know a lot of people took a while to receive their letters and all of them said 12 weeks. So I've put in bold here, it is the same for everyone, that shielding is due to end on the 30th of June, regardless of when you received your letter, regardless of when you managed to get added to the shielding list, anything like that. Shielding ends on the 30th of June at this present moment. And in terms of further announcements, we're expecting something in the next 48 hours, which obviously isn't perfect timing for this. So we can talk about what patients may or may not like to do if things happen, but unfortunately we aren't able to give you any certainties on shielding today. There have been some media reports that it will be extended to the end of July in England and then will officially end. But if you've seen this, I just wanted to point out that this is speculation at the moment. It came from some sources within government, but there is no a sort of official yes or no that will be the plan. So if you're shielding, what can and can't you do? Just to be clear, as this has also changed in the last couple of weeks. So you can leave the house to exercise. This is advised to keep to once a day and maintain the social distancing. There is a bit of a complicated rule around if you live on your own as the shielder, you are allowed to spend time outdoors with one other person, keeping 2 meters away from them. Whereas if you live with others, that doesn't apply to you. It's also very important to say that you should avoid any indoor spaces. So don't go shopping, don't go out for essentials and that sort of thing. Support is still available until the 30th of June. And then hopefully support will continue if shielding continues. Obviously, the exception to the indoor spaces is for medical appointments, which I'll come on to in a moment. What about the other people in my house? So a lot of people are being encouraged to go out more, to the shops, to work and things like that. If you're concerned about maintaining shielding, the advice to social distance from people within your house is still in place, and there's just a few examples of what you should do to maintain social distancing at home. If you have concerns about this long term, please get in touch with us at Leukemia Care and we will see what we can do to help. And what about visitors coming to your home? So there was a recent announcement about support bubbles, which I think gave a little bit of hope to shielders, but unfortunately those announcements didn't include people who are shielding. You can meet one person outside if you lived alone, as I mentioned with the exercise, but you should not be meeting others within your home, and that includes within your garden, and you should not have overnight guests. Overnight guests are not allowed unless you're in a support bubble. I just wanted to end by talking about guidance versus the law. So there's been a lot of talk about, what is and isn't allowed, and lockdown was set up as a bunch of things were made unlawful within the whole general public lockdown. Shielding was guidance, but it was guidance designed to keep you safe. And we appreciate there are ongoing challenges and questions around shielding, which we'll discuss today. But I think it's also important that while this is not mandatory, if you're going to make changes, have a discussion with someone about those changes and talk about the risk before you make those decisions. The final thing I wanted to talk about, I'll let my clinical colleagues talk about this much more, but there's been a lot of concern about patients not attending their medical appointments as they should. And I just wanted to say that if you need help, please go and seek that help from your haematology team. This is especially important if you've got symptoms that need checking out, because you can still receive treatment. And hospitals are putting things in place to keep people safe. There are zones, there's PPE, there's all sorts of things that can be done to keep you safe while you need medical treatment. I think I've seen a lot of people sort of share their stories online of going to the hospital and how it wasn't as bad as they thought. So try connecting with others who have already been to the hospital and ask them how it was. And I think you'll find that actually there's much more in place than you might have otherwise thought. And I just wanted to put a note in here about our Spot Leukemia campaign. There's been a lot in the news about how cancer patients are perhaps not coming forward, or potential cancer patients, people with symptoms who might or might not have cancer but need to get checked out, not approaching their GP. And we'll be still doing our Spot Leukemia campaign this year to try and raise awareness of the symptoms, and any help you guys can provide with that would be very important. So I'm just going to pass over to Renato, who's going to give a few interesting facts about COVID that you may or may not have heard before. And then we'll move on to Amit and Adam, and then we'll have a bit of discussion about any questions that you may have. So please share your questions while Renata's talking, and we'll get to them as soon as possible. Thank you.
Thank you, Charlotte. Good morning, everyone. My name is Renata Walewska, and I'm practicing in the southwest of England. My special interests are chronic lymphocytic leukemia and lymphoma. I would like to refer you to the previous webinars, which were organized by Leukemia Care. They're full of very, very useful information. So what I complied here is something you may not have heard before. Next slide, please. So first, I would just mention about 2-meter distancing, because you probably heard yesterday in the news that government, for economical reasons, planning to reduce it down to 1 meter. About BAME and effects that has got in healthcare at the moment. Information about public toilets. Also, the data on 22.4% population needs identification protection. So this is all about how to shield this group. Briefly about antibodies and vaccines. Again, one slide about mutating virus. Very brief snapshot of EHA update, and what I think is very important currently with social media about fake news. Next slide. So masking and eye protection, it's not new. I went to a range yesterday and they were already selling the eye protection, and these are pictures from which I unashamedly borrowed from Professor Trish Greenhalgh from her tweet, where in New York in 1919 they were already using eye protection and masks. As you know, probably as you've seen in America, wearing masks is some kind of protest against freedom, and yet back in 1919 that was not such a big deal. And obviously we learned quite a lot on how about public health medicine, and this is from years of epidemics. So I'd like to refer you to a book called Epidemics and Society, from Black Death to Present by Frank Snowden, which which elaborates how much we learned about pandemics and epidemics. Next slide, please. And a couple more 1919 pictures. So again, stay at home. So it has never been easier to save lives. This is a poster from 1919, 101 years old. Next one. And telecommunication, as you can see, Bell telephone is the one to use, obviously in 1919. We moved on slightly from that. And read how to prevent influenza. Do not take any person's breath. Keep the mouth and teeth clean. Avoid those who cough and sneeze, etc. I'll leave it to you to read. But again, it's amazing that basically we're rehashing all that very good advice again. Next slide, please. So yesterday, when Sunday Times landed on my in my house, I've seen the headline about reducing to 1 meter, and I started wondering myself, where did it come from? So obviously up to now, it was 2 meters. In America, it's 6 feet. 6 feet is not exactly 2 meters. So this is from WHO recommendation, where they suggested keeping distance of at least 1 meter. And this is based by this paper from Lancet. And this paper says that risk of infection is 13% within 1 meter, and 3% beyond that. But really what it goes down to, where it is. If it's in the open area, obviously risk is much less. And obviously also if the patient, both people are wearing masks. And here you've got lists of different distance rules depending on country you live in. So of course 1 meter move by UK government is purely economical, because when you think how you, for instance, you sit people in the cinema, within 2 meters, that's almost impossible, but within 1 meter, that would be quite doable. Next slide, please. Moving on, so Black, Asian and minority ethnic. So it was quite astounding a few weeks ago when there were pictures of doctors who sadly succumbed to COVID. And it was quite staggering to see how many of my colleagues who were from BAME community died. So that's a real problem. And obviously since there was obviously publication quite a lot, this is just an example of publication I put for a patient. So obviously BAME became a risk factor for COVID. And for instance, in my hospital, each doctor, each healthcare workers, when they coming back to work, this risk is reassessed again. Next slide, please. What I found interesting is about risk of public toilets. So we know that obviously COVID is transmitted mainly through respiratory droplets, but feces can be also infectious. So we know that from SARS, from MERS, so these are previous coronavirus predecessors. So there was a publication in Physics of Fluids. So if someone uses the toilet and that patient is infected and it flushes the toilet, that creates aerosol, and that aerosol can go up above the toilet up to 3 feet and can be obviously infectious. Now, the author says it's still attending the toilet is still less risky than attending closed public gatherings. But what is important, toilet ventilation, mask, cleaning those toilets frequently, simply with soap and water, and also the advising on installing lids which close automatically before the toilet flushing. So we've got that all at home, but when you go to public toilets, there are no lids. Next slide, please. So this is all about shielding, and this webinar is about shielding. And there was obviously a recent publication from Lancet Global Health, which this is a worldwide figure, of course. So there is 1.7 billion people worldwide who are at severe risk of COVID-19. And hopefully on this seminar, we'll be discussing how to identify those people and how to protect them. Next slide, please. So let's quickly go to antibodies and vaccines. So there was a very small publication in Nature Medicine, only 37 people, showing that antibodies disappear between 2 and 3 months after infection. And more so, we were talking about, we must have heard about super spreaders, so asymptomatic patients, and their level of antibodies, it's even lower. And this is a very nice diagram from JAMA, which shows what happens with virus level, antibodies level, and which test can be positive. So the message for the antibodies, so we need to utilize the test, virus test together with antibody test. Next slide, please. And what I found quite interesting is there is on New York Times, and this is a link, coronavirus vaccine tracker. So this is updated from the 19th of June when I prepared the slide. So you can see in clinical state, there are more than 125 studies. Phase 1, so this is phase 1 when study is going through for safety and dosage, 10 clinical studies are running. Phase 2, which is extended safety data, 8, and these are the type of vaccines being run. So this is mRNA type vaccines and protein vaccines. Warp speed means that this project has been picked up by US government. So if eventually, if they decide that this particular vaccine is very promising, they will get federal funding, significant federal funding. Then there is 2 large scale efficacy clinical trials with placebo. So there are 2. One of them is AstraZeneca Oxford study. Again, this is a warp speed, but so far, none of those vaccines are approved. Next slide, please. And what's quite important to bear in mind is that this virus is constantly mutating. So there was a publication from UCL group from May 2020, which on the basis of mutation of coronaviruses showed that this coronavirus did not come from one index case, but entered UK from numerous exits independently because they had a chance to compare what happens in other countries. And also there was a hope at some stage that maybe that this virus will mutate itself out to a benign form, but that's not the case at the moment. And understanding how this virus mutates is very important for future effective treatments and vaccines, because obviously you want vaccine which will continue to recognize that virus, even that virus has mutated. Next slide, please. So I would like to finish on how to recognize fake coronavirus news or any fake news. We've been bombarded by this. You've heard of papers being retracted, and there is actually a website called retractionwatch.com where you can have a look at those papers which were retracted, and there's obviously it's unprecedented number of papers have been retracted. So how to spot a fake news, and WHO it calls infodemic. So obviously because of COVID, we've been bombarded with information on anything related with COVID. So first, if the news is vague, so for instance, untraceable source, a Dutch scientist or a doctor of the friend of the friend of a friend. If there is a bad language, so poor grammar, spelling, punctuation. If there is emotional attachment to that information, so something which makes you angry or very overjoyed, and this message, so the whole idea behind this message is to trigger strong emotion. Fourth, if this information is only reported by one source, so that's obviously suggested that something is trying to be hidden from you. False accounting, so always check what BBC Newsnight is not BBC News Tonight, and always check the email, because just one character obviously will change your email, and you can be fooled by that. Oversharing, so if somebody on their Facebook tells you, urges you, oh, you must share this sensational news, that should raise a red flag. Follow the money, so ask yourself, who stands to gain from this believing of this extraordinary claims, and fact check. So if it's too good to be true, it's not true. So as I said, there is a retraction watch. There are plenty of good websites available: Leukemia Care, CLL Association, Royal College of Pathologists, Lancet, WHO. But next slide. One of useful recent is an app which it's intended to create a global COVID survey. So this is an app created from King's College London, and the whole idea, so basically anyone who thinks have got a COVID can self-report their symptoms, but within that app there is also fantastic and very useful updated information. And before I finish, I would like to say that obviously we, as a hematological community, we have adapted now. We've been in this situation for a number of weeks. Our treatments have become much safer. We treat patients only who we have to. Any treatments who can be deferred, we defer. So I would urge you to come to our hospitals if you don't feel well. So we've got special zones, as Charlotte mentioned. We've got now green. There used to be red zones. So we don't have red, we've got blue now. Obviously red is a bad color now. So we've got green zone in hospital and blue zone in hospital. My hospital, for instance, is testing all this stuff. We're slowly starting autologous stem cell transplantations, and all doctors, all nurses, all cleaners, HCAs will be tested for virus. So I already had an antibody test, and I already had a viral swab, and I just actually came back from quarantine because I had a contact with somebody who was positive. So the hospital is tracking and tracing. This morning, hospital looks completely different because even in secretaries' offices, everybody's wearing masks, everybody's washing hands, there are gels everywhere. Also, our clinics are completely different. All my clinic this morning, I'm doing telephone, where there are difficult discussions, especially with family members and specialist nurses. We do it on video conferencing, which is a software called Attend Anywhere. And also some consenting to chemotherapy is done on that before we actually do. So explanation of the consent are done on video clinic. And then obviously when the patient actually comes for treatment, then they sign the consent form. And finally, if the patient does need to come in, we're trying to stagger appointments. So we're trying to make sure that we don't exceed waiting room capacity. So I think, thank you. This is probably a quick snapshot from me.
Thank you, Renata. That was interesting and perhaps hopeful, what you said about 1919 and how they were doing all sorts of crazy things and then they went back to normal. So hope for us yet, I think, from those ones. Adam, did you want to add anything to Renata's first statements?
I'll be fairly brief, I think, just so we can move to doing some Q&A, which I think is very useful for everyone. So I'm a haematologist in Oxford. I specialise in particular in myeloid neoplasms, myeloproliferative neoplasms, myelodysplastic syndromes, chronic myeloid leukemia in particular. I'd make a number of comments. Firstly, I think it's important to remember how much progress has been made in the control of this virus in the country. So the outbreak is under increasingly good control in the UK, and all the time the number of tragic deaths occurring as a result of the coronavirus infection are decreasing. They're about 10% of the levels that they were at the peak at the moment and continue to decrease, so that's good. We're making really good progress in terms of understanding how to treat people who've got severe coronavirus infection. So you would have seen the results of the recovery trial that was led from Oxford, showing how dexamethasone, a treatment that's widely used in hematology patients, in fact, can have a very impressive beneficial impact in patients with more severe disease who are needing oxygen or needing more intensive support. So that's a big breakthrough. But there are other breakthroughs with antiviral treatments, remdesivir, and some anti-inflammatory treatments too. So great progress being made all the time with regards to the vaccine. I had my vaccine yesterday on the Oxford clinical trial. So that's recruited unbelievably well, over 4,000 patients on the study. The big problem, which is a good problem to have, is that there aren't enough cases in the UK at the moment for them to reach a conclusion about the trial. It's a nice problem to have, but because of that, they're running the study in Brazil. So I'm pretty hopeful that trial will have some news for us towards the end of the year. So I think there's lots of progress being made. I'm happy to take any specific questions about how to configure the service and patient care in the context of the outbreak, but it's probably better to take those questions as more specific Q&A points. So I'll hand over to Amit now.
Thanks, Adam. Amit, did you want to add anything from your perspective?
Yes, so thank you, Adam and Renata. I think there's not much for me to add, really. I think what we know is that patients with blood cancers remain at increased risk, particularly in those patients who have low blood counts. We know that from data in international registries, particularly in the American registry hosted by ASH, the American Society for Haematology. And we also know that patients with acute leukemia, AML or ALL, or other causes of bone marrow failure, those patients at the time of diagnosis or at the time of relapse refractory disease, so both times when blood counts tend to be very low, both neutrophil count and lymphocyte count, those patients tend to be at higher risk compared to at other times in the patient journey. And we also know from this data set that patients that have any form of cellular therapy, whether that's allogeneic stem cell transplant, autologous transplant, or even CAR T-cell therapy, the numbers of patients treated, of course, are relatively small that have had COVID-19, but those patients would nonetheless be at risk. But in terms of recovery, half of the patients post-allogeneic stem cell transplant in this registry recovered. More than 2/3 of patients who had an autologous stem cell transplant that got COVID-19 recovered, and all patients who had CAR T-cell therapy and then got COVID-19 recovered. So I think there's some positive news that we have treatments that are available and a vaccine, as Adam was saying. And as the prevalence of the disease has gone down, it seems reasonable to revisit the stringency of the shielding, that the government is evaluating this week, and hopefully we'll get some clarity on that. But I think it might now be a time to think about some limited lifting of the very, very difficult shielding that has been implemented thus far by the government, quite rightly, as the prevalence was high. But as that's come down and there are some more treatments available, I think it's worth just thinking about being more nuanced about that for some patient groups.
Great, thank you, Amit. Nick, to bring you in now, do you want to just give a sort of patient perspective on shielding and also what we know as leukemia care, how patients have been getting on, and then we'll get into the questions as soon as possible.
Thank you, everybody, and good morning. I think Amit very neatly dovetailed us into this discussion. When we look at patients at the moment, looking at our surveys, I took myself as a patient, we're used to living with uncertainty, but the current uncertainty is becoming a little bit more oppressive. And as lockdown has been lifted around patients around us at the moment, how to mitigate our risks and understanding that, from the reports in the media, looking at the evidence that this is going to be going, that COVID's going to be in the community for some time. So as we are leaning towards potential social distances being shortened, is how can patients mitigate their risks to be able to operate in an environment where we're being encouraged to go outdoors for exercise. There's advice with regards to certain times of the day, do it when there are fewer people around. At the moment, we're not able to associate with others indoors, and we're not enabled either to have safety bubbles indoors. So one of the ongoing impacts at the moment that the patient groups and our surveys are reporting, if we look at 1,000 patients from a recent CLL study, and it's been reiterated in other studies that 18% of people were not coping with shielding, and that was before we were able to have a little bit of exercise, to have the courage to be able to stick our necks out and go for that first walk. So I think part of the problem as well attached to this is how do we build confidence? How can we get confidence that our actions are the right ones when the information we're getting is mixed, and when often it doesn't seem to be on or believed to be on science? So you guys are really important to this at the moment. And 10% of patients who have been shielding now for 3 months have actually confirmed in our surveys that they wish some psychological support. They want access to some psychological help and counselling. So that's the impact that's been happening. So moving forward, we've obviously received the news, and we're having to be a bit speculative, is that we understand that shielding in its current form is likely to end. I think that's a practical point of view as well. And as Amit has alluded to there, so we'd like maybe in this discussion have some chat as to what shape it might become. How will patients potentially be stratified in the future? How do you measure risk? I know it's a prickly subject, but it's moving forward. How can the immune compromised community, which is us, be more vigilant, remain vigilant, mitigate our risks? And what should we do if social distance is shortened? Should we all wear masks no matter what when we're out? Should we still keep 2 meters away from everybody? Should it change? So these are areas I think we can see some impending change. I think the idea really is I'm going to hand it over to you guys to chat amongst yourselves, is how can we prepare? And most importantly, confidence in maintaining. I myself, I'm a very experienced patient, but I need blood tests at the moment, and I'm a little bit nervous to go and get my blood. Yeah. The surveys confirm that our clinical community has done a fantastic job in maintaining engagement with us, has shipped us in advanced medications. We don't have access at the moment to some routine prophylaxis, IVIG, for example, in the CLL community and other. So again, it's confidence moving forward. So I think that's me sharing our perspective, and then from that I can then field everybody's questions. But I was just wondering if you wanted to chat amongst yourselves briefly on some of this topic.
Yeah, I think, it's all about trying to get a sense of the risk, and the risk now compared to the risk 10 weeks ago is very, very different. So, it's difficult to know what exactly the rules will be, but what we do know for certain at the moment is the number of people actively infected with coronavirus at the moment is low and decreasing. It's less than 1 in 1,000 at the moment. So if you think about the kind of daily interactions you have, if you're not shielding and you're going out and about, it's a small number of people you would come into any kind of close contact with under normal circumstances. So the risks would already be quite low. If you add on to that, additional measures that we can all take to minimize those risks, social distancing, 1 meter or 2 meters. I'm a great proponent and fan of mask wearing. I think the evidence is pretty good in support of that. And all hospital areas, there's a lot of mask wearing. well, it's compulsory now for face coverings for anyone entering the hospital building, and for all staff, they will be wearing surgical type masks wherever they are in the hospital. That's going to have a big impact. So the risk is much, much, much lower than it was, without question. What everyone should remember is masks are important, social distancing is important, but washing hands remains really, really important. That is one of the key routes of transmission. And, you know, the same core message that sometimes gets forgotten about regular washing hands is really, really important. So my father, just to give you a personal example, has got chronic lymphocytic leukemia. He had exactly the issue you raise about receiving IVIG prophylaxis, and we spent, you know, he's been shielding and was very nervous about going to the hospital. And you know, what I would encourage people to do is have a dialogue with the hospital team, because they will really, really try to accommodate you and make sure that the risks are absolutely minimized. And there's so much effort and thought being put into that. So in his case, they gave him the IVIG in the end. You know, the nurse came in early because she's a dedicated nurse, and he had the IVIG on his own early in the morning, everyone wearing masks. The experience was very positive in the end, and he felt hugely reassured. So what I, you know, it's going to be different from center to center and staff to staff, but what I would encourage everyone to do is to speak to their healthcare team, because what my sense is at the moment, and I'm really concerned about this, is that we're going to be doing more harm if we're not careful by being too risk averse with regard to coronavirus and not getting the appropriate treatment for the blood conditions. And you know, in order to do that, you have to discuss with the team, and they will put into place whatever measures are required. For example, blood test monitoring you mentioned. We've got a fantastic setup in Oxford where essentially it's a drive-through system. So there's no waiting, you're not in close proximity to anyone else. You drive through, have your blood test, you don't come into contact with anyone apart from the person taking the blood, back in your car, straight out, all done in the car park remotely. So all trusts will be doing similar things. So I would just encourage people to have a dialogue with their local healthcare team, and it's really, really important we start reactivating the kind of close as possible the norms of care and management of these conditions.
I would like to second that. I agree with everything what Adam just said. So just to add maybe a couple of things. I think the patient actually will know how the level of immunosuppression they are. Now, for us, this is very difficult, and we discussed that in CLL forum, whether we can create some kind of algorithm. The problem is we've got no really data to create that algorithm. But I think if patients are generally well, they don't get recurrent infections, they will have less risk. But somebody who needs to have prophylactic antibiotics, who needs to have IVIG or subcut immunoglobulins, who is on, like unique, on ibrutinib, their risk is much higher. So again, you do need to discuss that with your clinician. And unfortunately, we cannot create an algorithm that would fit all. And you know, prevention is better than cure. As Adam said, it's much less risk to catch the virus now. But if you understand your own risk and you take precautions and you prevent them, then you are safe. And prevention better than cure, it's actually, that phrase is origins from 1500s. So from the old epidemic and from the Dutch philosopher Erasmus. So we knew that for hundreds of years.
Amit, do you want to add anything to that?
Yeah, I would agree with those comments. I think hospitals have taken lots of precautions to try and help mitigate the risk, which can't be eliminated. But I think hand washing, managed with alcohol gel use at the entry points of hospitals, surgical type face masks or coverings, and minimizing the interaction. So the number of interactions with people and the time within those healthcare environments, I think has been quite helpful. And you know, as Nick alluded to, some patients actually are followed up remotely. So patients are now being offered telephone and, where possible, video consultations. You know, and at our hospital, at the Christie in Manchester, we've tried to do that. So we've tried to make sure patients reduce the number of visits, so the footfall has reduced, and the time required and the environment in which those visits occur. So, for example, you know, for blood cancers, blood tests are fairly fundamental to the assessment. So if those can be done, you know, remotely, or in our case, in a blood drop area, and then patients can go straight back into the car, then I think that's a very good advance. And actually, some of these are quite convenient in the sense that, you know, they may end up staying as part of routine care, because actually from a patient experience point of view, they are potentially better than what we were doing before. You know, patients coming in, sitting in waiting rooms for endless amounts of time, and then having a consultation and going. Actually, reducing that has been helpful. And I suppose that the one last thing I'd comment on is the fact that I think most patients with blood cancer, certainly patients with acute leukemia, or patients treated with transplantational cell therapy, those patients would always be asked to socially distant. And you know, those patients would always be asked to, for example, not use public transport, to try and avoid lots of contact in busy areas, would be asked to sort of go shopping when it's less busy, and go to places when they're less crowded. And I think that those precautions, getting back to some kind of normality where we don't need to be strictly shielding in the way we have been, and moving towards a transition where patients can actually, you know, have a bit more time outside, meeting other people at a distance in the open. I think that those things are all helpful. And certainly one thing we've noticed is that typically you would, in the patient group that I look after, see lots of respiratory viral infections, so flu or parainfluenza or respiratory syncytial virus and so on. We just haven't seen those, and I think we haven't seen very many of those because the distancing has been helpful. And as Adam was saying, actually the hand washing and the sort of basic hygiene measures have been very well implemented, and patients have sort of been very vigilant about trying to do this, you know, much more frequently than perhaps we have done previously, or been able to emphasize previously. So I think that there are additional benefits in terms of preventing other infections that you can get from maintaining some degree of sensible physical distancing, but clearly, you know, making sure you're getting out and about, because I think otherwise, you know, as Nick alluded to, this is not a sustainable situation. You can't cut yourself off from society and friends and family and so on. The issue about delaying treatment is also important because, you know, well, 3 months ago we had a situation where we temporarily modified services. IVIG is a very good example, to try and make sure that we reduce contact and therefore the risk of infection. But then there comes a time when the balance of avoidance cannot continue, and we then need to get on and make sure patients are getting whatever treatment they need for whatever disease type they have, whether it's whether it's active treatment or prophylaxis or something similar.
If I could just add one more thing, I think it's very important, as we just said, just to lift the shielding and let those vulnerable patients out, and enjoy, obviously, do things, have exercise, meet with other people. But I think what is important, and it still does continue, that government provides support, and they've got deliveries of food, of medication. So especially those people who do not have good network of family around them, and that support still continues.
Can I pick up briefly on just one point about the masks that people are raising?
Yeah.
There's an important point. Masks do offer limited protection for you as an individual, but they're much more important for preventing someone that is infected with the virus infecting other people. So that is the strongest reason for wearing them, but they still do offer some protection for you as an individual. But we don't recommend that patients will be wearing surgical grade masks. They can wear face coverings, same as anyone else. I'll hand back to Nick because you're fielding the questions next.
Well, I won't field too many, thank you. I shouldn't really need to, actually, because you can see most of them. I think the first thing to say is thank you, all three of you, for sharing how services are being delivered and how you're mitigating risk for patients, and reflecting on the vast number of questions from everybody who are confirming they're using services at the moment for bloods and attending hospitals are experiencing and the feeling of safety and personalised care that they're getting there. So that's obviously working. I've got a couple of questions that are still there, and maybe Charlotte could also pop in on this one. It's great these services are available, but there's a significant proportion of people who are using public transport or have to or had to before COVID. So I just feel this one is what's your advice for patients who normally used public transport, and what are you able to put in place for patients who are unable to get there under their own steam, or ideally wouldn't want to do so in the car with somebody else that they're not shielding with? I field it to any takers.
Want me to go first?
Yes, please.
I just wanted, I guess, to mention that we have still got a hospital travel fund open. So if you do need to go to a hospital and you need to take some other form of more expensive transport, so a taxi or something like that, get in touch. And if we're not able to help through our fund, we will try and help through something else. And then I guess it's probably best to leave it to one of my clinical panelists to talk about sort of alternative options. I'm sure there are some somewhere.
I mean, I think it's a very important point, the public transport issue, because in non-COVID times, we would typically be asking patients having treatment for leukemia or a transplant, that we would be asking those patients to avoid using public transport, and we would typically be asking them to be in their family bubble or their household bubble to try and help with that movement from home to hospital. But clearly that's not available to everybody, and some patients don't have that. And I think the fund you mentioned, Charlotte, would certainly be very well received, I think, by patients in that situation.
Does anybody else have any thoughts to add?
There are, for instance, in Southwest in Dorset, where I practice, there's loads of volunteers who are providing free transport for patients. Of course, there is a risk that driver could be positive, but they should self-isolate, obviously, themselves if they're unwell, and they're always wearing masks. So I think it's worth checking whether that's something available in your area.
I was going to add to that, just sort of following on from where we discussed some of the psychological challenges patients are receiving, and I think there's comments in there from one or two people, and even a healthcare worker who's unable to signpost to psychological support, that's an area that potentially the charity can also support. I'll leave Charlotte to explain that area at some point. I was just looking at how, following on with the questions about how risk is likely to, people can manage their risk. And it's not just their disease and understanding where they are with their own type of disease. There are other issues as well. Obviously, the bulk of the population are asked to be mindful of their existing other illnesses or conditions that make them vulnerable. And obviously location is a key one. And that's another big area that we have as patients, and probably the general population. You know, nobody knows at any moment in time what the infection risk is in their area. Have you any thoughts on those two topics? Obviously, I'm assuming this would be part of how, in the future, people's risk would be managed by healthcare, and, you know, looking at those three areas, as well as, because quite a few people have alluded to the fact that they might have a particular blood cancer and be at a stage of their cancer where it doesn't significantly put them at potentially at a really high risk. But at the moment, everybody has got a one size fits all cautious approach, and with this changing, any thoughts about how you will be, I suppose from our point of view, the advice is that we should have everybody talk to their specialist team if they want to understand their risk. How are you fixed? How are you with people contacting you when they want to understand, if they've got any confusion as to what they should be doing? I think ultimately you are the mediators to advise patients.
Yeah, I mean, that's what we're here for. So I've been fielding lots and lots and lots of queries from my patients, and very happy to continue to do so, as are the rest of the team. One important thing with respect to that is I think particularly for blood cancer patients, as coronavirus decreases in the incidence, you know, we've got to remember blood cancer patients get unwell for other reasons, and we've had isolated incidents of people with fever who are getting advice that wouldn't necessarily be the right advice if they'd contacted the haematology team. So we're very, very much encouraging all our patients to directly contact the triage service in haematology rather than 111 and so forth. And final quick point is with regards to knowing the risks in your particular area, there is actually a very nice portal from the government where you can look specifically at the number of cases, quite up-to-date data. So I was just looking before this call, you know, in the West Berkshire area, there were 2 cases out of about 400,000 people in West Berkshire in the last week, 2 positive cases. So, you know, that gives you, at least in our area, a kind of localized sense of the risk. Clearly, the tests are not going to capture every positive case, but they're probably capturing about a quarter of the cases at the moment. So that tells you that, at least in our area, the number of people walking around with coronavirus is very low indeed.
And if I could add to Adam, we know our patients, and we're taking risk together with any other potential risk. So other comorbidities, age, obesity, because obviously any risks which can compound a risk of COVID, that will change. So yes, absolutely, all hematology patients should be contacting us, hematologists, rather than 111.
Thank you.
I couldn't agree more. I think we touched on this on a previous webinar. I think the advice should always be, if you do get those symptoms of fever or breathlessness or fatigue, or, you know, that the government is suggesting are indicative of COVID, it is very important to follow the government advice, but also to touch base with your hematology team. And, you know, our centre, like I'm sure every other centre, will be very keen to provide advice, because it's not, I don't think it's not most appropriate to go to 111 first. It's better to go to your hospital and your haematology team first, because, as Adam says, actually what we know is very common in patients with blood cancers or whatever treatment they've had is infection, not just coronavirus, but other bacterial or other types of infections, which will require different and specific treatment. So it is crucial that occurs. And I suppose the other thing in terms of managing risk, I would just consider, you know, adding from onto Renata's point, is if you think about yourself and not think about the type of blood cancer you have, you know, does your age put you in a higher risk group? Does your ethnicity put you in a high risk group? Does your gender put you in a high risk group? Does the presence of chronic liver disease, lung disease, heart disease, anything else put you into a high risk group? And then actually when you consider those other aspects and you add back the blood cancer risk, actually you find, regardless of the blood cancer, you're in a high risk group and therefore need to continue to have slightly modified behavior, going forward until this is the disease, the pandemic is at a later stage, because those risk factors, particularly age, being over 60 is in the UK data set has a similar risk to having a blood cancer. That is a not insignificant risk. Being 70 or above has a much higher risk than having any blood cancer in that data set. So it's just important to put all of those risks into context and look at things in the round, because of course, as haematologists, we're obsessed with the blood cancer diagnosis, but actually the rest of the risk profile may still warrant having very careful behavior, even if the type of blood cancer itself doesn't.
I just wanted to ask, sorry Nick, I've got a question that a lot of people have asked, but I was also thinking, a lot of people are asking about whether their job should be something they consider, whether they go back to work or not. Is that something that you would also include in that risk assessment when you were talking one-on-one with patients? Do you feel able to advise on that as clinicians?
Could I add to that, Charlotte, as well, the questions that have been coming in with regards to people and family members returning to work, and also children going back to school, and concerns. Obviously, they've all been shielding together with these imminent changes. These are big problem areas for people.
Yeah, I mean, that's our job to talk through with patients, about the relative risks of going back to work in that situation, depending on their personal circumstances. So I've been spending a lot of time doing that with patients over the past few weeks. And, different patients have got very different perspectives on this. Some patients are very keen actually to continue shielding and minimizing the risk, and others would like to get back to some kind of normality if I can offer them some reassurance as a clinician that that's a reasonable thing to do, which often it is actually. So that's our job, and that's what we do on a daily basis, and that's what patients should be seeking from their haematology team. I think some personalized advice about their personal circumstances and particular risks depending on what disease they have and what treatment they're on. It's really important to remember, one cannot group all the different blood cancers together. It's very, very likely that some patients are at very high risk, and other patients with certain blood cancers may not be at any increased risk. We're still learning a lot about that, and there's still many unknowns, but we can still do our best as clinicians to offer what we think is sensible advice depending on people's personal circumstances.
I've got a couple of questions. There's obviously an enormous number of questions from everybody, and we will follow up the questions and send to panel afterwards. I hope you don't mind, panel, if you'd be able to answer that so we can feed back to people. There's a couple of that have come up that have been repeated quite consistently. I mean, one of them I'll take from earlier is blood cancer patients may experience symptoms of minor constant infections. I know I do. And if I've picked up the phone every time to 111, I had symptoms that I thought might be COVID related. I'd probably have COVID by now. So I just wanted to clarify your question there. If people are if they're experiencing COVID-like symptoms, should they also be contacting their haematology teams rather than 111?
Yeah, well, we've been advocating doing that for our patients. They should contact us because they could have COVID, they may have something else, or both. So I think it's very important to touch base with your haematology team, and most haematology teams will offer some sort of direct contact to either the consultant or somebody else that's covering for them.
Well, you'll obviously, I hope, you may end up with a deluge of calls after this, but there's one that's been constantly repeated. I know it's some way off in future before we may have the offer of vaccines on the table, or possibly clinical trials before that. A lot of questions are coming up is how many of the vaccines are live or aren't suitable? Are they suitable for immune compromised patients? I wonder if somebody's able to allude on that. Somebody mentioned the Oxford one, for example, is live, and there's been quite a few others around that area.
Yeah, there's a huge number of vaccines in development, over 100. The two leading ones are the Oxford vaccine, which is a chimpanzee adenovirus live but inactivated vaccine. You know, could that potentially be used in patients with blood cancers? I still think it could. In fact, I was part of a collaboration with the Oxford team with the idea of developing exactly that same type of vaccine approach in patients with myeloproliferative neoplasms. So you know, I think it would have to be done carefully and in the context of careful clinical trials to assess the safety. And there may be certain groups of patients who you wouldn't want to offer that type of vaccine to. But the Moderna vaccine, which is also pushing forward at a very rapid rate, is not a live vaccine. And the Imperial College vaccine is something called an mRNA vaccine, which is not live as well. So there are going to be plenty of vaccines coming through that do not involve live virus.
And if I could just add to that, the other important thing about vaccines, because for instance, my population, CLL patients probably will not respond well to that vaccine is to create a herd immunity. We've heard herd immunity before, but if herd immunity is created by vaccinating the whole population, that's the ultimate aim. But obviously to do that, that's going to take much more than a year.
Thank you. That's really insightful. I just wanted to, sorry, a couple of quick, there's been a lot of questions about people asking about group exercises on bikes, running, having more than one person in their garden at a time. And I just wanted to allude to that. I think the guidance, and Charlotte can clarify, at the moment, it's only one other person is allowed to be able to join you in your garden socially distanced. And if you're exercising outdoors, that's the same. Can you confirm that, Charlotte? There's quite a few.
Yeah, that's correct.
Itching to get going.
I mean, I'm just listening to what all the clinicians are saying. I think it's important to remember that it's sort of every extra contact you have is extra risk. So try and stay within those shielding guidance and where you can. So avoid indoor places in particular, stick to the outdoor. And if you have to meet up with people, think about whether the risk involved is worth what you're trying to achieve from that. And the guidance is only if you live alone. If you live with other people, obviously there is an assumption that you'd have that social contact with them. And clinical panelists, please feel free to add to that if I've sort of not interpreted what you said correct.
No, you have. I think looking at all of the questions, and we will get back to everybody else. Risk measurement is not straightforward. You know, there are other questions coming in with regards to, does your job alter your risk stratification if you're, you know, in a key worker role? And I think the take-home message I'm getting at the moment from everybody is if you're indecision, if you have indecision about what your risk status, if you're unsure, speak to your consultant. Or your specialist care team so that they can help with you evaluate what you can and can't do. And then ultimately, if you've got the information you need, then we're all adults. You know, you make the best decision you can to ensure your own safety.
Exactly.
Yeah. Charlotte, do you have anything to add at the moment? I think looking at the time, we're coming close to time. There are a raft of questions. I mean, there is one I could ask. A few people have asked in the past about use of certain treatments to, you know, does that reduce their risk? You know, somebody's mentioned the calibrutinib, and I know in CLL and similar inhibitors in other diseases. I'm assuming from that, this is, there's no evidence for that, and patients should speak to, if they've got any questions in that area about treatment impacting or how their care might impact on their risk, they should talk to their specialist care team.
Yeah, absolutely.
Yeah, there is a clinical trial actually looking at those kinds of inhibitors, not just in patients with CLL, but more broadly in patients with blood cancers. But as you say, there isn't really any evidence to support use outside a clinical trial.
And I think if I just could add something about key workers, and I've obviously noticed a lot about working. I think obviously if you employed, talk to your employer, because for instance, our specialist nurse is working from home. She's got NHS laptop and she does excellent job contacting all and supporting all my patients. Also another patient of mine who's had a Hodgkin lymphoma recently. Again, she's a nurse and she's working from home.
I'll head back to Charlotte. I just want to thank you all, because as a patient, you have given me a lot more confidence, and I should have more confidence considering how engaged I am, but I'm just human. I've been locked in my garden for 3 months. I've got a wonderful garden now, and I'm fortunate to have a garden, but I haven't had a lot of confidence, and I've snuck out every now and then at with my dog in the mornings, but you've given me a lot more confidence, so thank you very much. And I'll pass you back to Charlotte.
If I could say, and I would like to thank you both for doing this fantastic webinars and for empowering patients.
Thank you, Renata, that's very kind.
Absolutely.
Thank you. Thanks again to all of our panelists, Nick and Amit and Adam and Renata. I know a lot of you out there, patient-wise, are wanting specific answers for yourself, and we're obviously in this format we were never going to be able to provide that, but I hope we've given you some context in which to make your own decisions, to empower you to make those decisions, and please talk to your doctors if you need further help. I just wanted obviously to show a couple of slides on what we've got going on at Leukemia Care at the moment, to keep yourself updated. As I said, within 48 hours is when we're supposed to be hearing more on shielding for England, and we will get that out to you as soon as we can, as soon as we know what's happening. But obviously we've got podcasts, our social media, our website, lots of sources of information available from us. And our support services are all still here too. We're doing support groups virtually. We've still got our nurse on the helpline. Recently we've brought in a welfare officer to answer your financial questions. Our usual advocacy support is there, so if you need questions, answers about clinical trials, about treatment access, please get in touch. And specifically on something Nick noted earlier about mental health, our counselling fund is still open, and we can help you to find some virtual counselling if that's what you feel you need during this time, so please do get in touch about that. Just leave those on the screen while we finish up, so if anybody needs any help, please do get in touch. Thank you again to all our panelists for a great webinar, and we'll see you next time. Thanks everyone.
Thank you.
Thank you.
Thank you.
Goodbye.
Bye-bye.
Bye-bye.
Bye.